questions. We listen in, we prepare some questions, we make it as engaging as possible. We're not trying to create an environment where we are only being told. We would like to hear your myths. We would like to hear the things you hear about cancer, cervical cancer, or probably extended beyond cervical cancer. We would like to learn from you as well. So today in the group, we have the team from YourFitPath. Starting off with the founders, we have Mr. Gaurav Sharma, we have Himanshu, and then we also have Fiona, definitely, who is our doctor here in Kenya. We have Sagnik. I do not know if I can be able to mention everybody's name. Locally in Kenya, we do have Dennis, we do have Wilson, we do have Maggie, we have Lisa on the call, we have another Dennis as well, and then we have Pancras here on the team. We have Victor, who are all together coming here to be able to make sure that this particular project, the webinar itself about cervical cancer, is going to be productive, and we can be able to also learn from the doctors who are coming on board to be able to support us. So apart from that, I think I'm going to be handing over to Fiona to take us to the next step, probably introduce the next person, guide us through the webinar, and then hopefully on the next steps, we're going to engage much more. Don't forget, let's make it as engaging as possible. Prepare your questions. Thank you. What I'm going to do is walk you through the introduction of what YourFitPath is all about, what exactly we do, and then again, probably from there, you can learn a couple of things and how exactly we are interconnected with the Indian side together with Kenya. What exactly do we do in Kenya? So first of all, what we're trying to do is just revolutionize. I think if you're watching on the screen now, you'll be able to understand what we're doing. You can be able to see what I'm talking about. We're here to revolutionize medicine in itself. We are thinking of the local Kenyan who cannot be able to get affordable treatment in a hospital in Kenya simply because it's expensive, yet they're looking for quality and better technology. That's where we come in as YourFitPath. So that is what the revolution we're talking about. What else are we? At YourFitPath, we are dedicated to basically create a transformation. It's a medical tourism platform. You want to go to India. How do you get there? How do I get the immigration documentations? Where will I stay in terms of accommodation? That's where we come in. That's where we are.
Sorry for interrupting. Can you just check once your screen? It's not visible actually, the presentation.
Hold up, I'll be able to come back.
Yes, now it's visible. Now it's visible. So
yeah. So I'm talking about our commitment. At the end of the day, we do realize the most important thing all through the journey of treatment is not basically only the treatment. It's the mindset before you begin your journey to treatment. And what we are telling our patients is, please do allow us to be able to give you a much better experience as YourFitPath. All through the journey, we're already going through a lot, and as a medical tourism organization, we are the link between the Indian hospitals and the local and the local plans to be able to get there. So that is our commitment. We want you to be happy, put on a smile as we get you the treatment that you deserve. Now, as YourFitPath, we also connect you to affordable care. What do we mean by that? Now, looking at Kenya, one of the things that you do realize as a country is, yeah, you can be able to access part of this quality treatment, part of it. Part of the technology is here. But then again, what is the price? You pay so dearly. And considering not so many families can be able to do this, that is where we also come in. So we come in to be able to provide affordable medical care, which is basically between 30 and around 50% more affordable. These are actually real figures. Sometimes it extends even beyond because we've seen that happen. Now, what else do? We make it very transparent, where by the time you live in Kenya, you already know this is the cost estimate of my treatment. Unlike where locally here, where you'd find that some facilities would want to keep you longer in the hospital when they really know that probably they cannot be able to support you in terms of treatment. So that's pretty much a lot of things that people go through, and we're trying to make sure that you do not go through that while you're getting your treatment abroad in India through YourFitPath as a medical tourism provider. What else do we offer? Second opinion. So you're in Kenya, you've already spoken to a doctor specialist. They're giving you all kinds of information, and you're looking to speak to someone in the global arena. India is the place to go. We find you a doctor in India. We create the time for consultation. You speak to them. Now, we also help you with visa assistance so that you can easily be able to travel when you decide to travel. Apart from that, there's the comfort of accommodation, which I've already mentioned. Now, we don't just give you a place to stay. We don't give you a room. We give you a place where you can have a peace of mind and feel like you're actually at home. So there's more to what we do, which I think we can be able to engage on a personal basis with doctors or patients who are interested in learning more about what we do. But at the end of the day, to us, the experience is much, much more than anything else. The doctors are going to handle the treatment. We support you through that process. Do you have a difficulty in payment? We support you through that process. We also help you with applying for the visa. Comes out in a record 24 hours. You can't beat that. Now, in terms of process, the only thing we normally ask for is basically just your details, the doctor's report, and then we're able to process this together with the doctors in India. We support you in terms of when you arrive in India and you're looking to get to the hospital. Do you need an ambulance? We take care of that. Do you need hospital selection? Because there are people who already arrived there and they're thinking, no, maybe the hospital I wanted to go to, I want to change. We support you with that. We help you plan your journey from the beginning all the way to the end. Now, why YourFitPath? I mean, you've been there already, you're suffering, you're going through a lot of pain. The least you want to worry about is the process beginning. How do I even start going to India? We come in strongly. We have a team of experts who are able to support you in terms of getting information, in terms of preparing the right documentations for you, including the passports application process. We do all that for you to ease the pain. Now, what are the benefits for the doctor? Rebranding. We would want to do that with you if you're collaborating with us. If you're a doctor in Kenya and you're doing referrals, so rebranding opportunities. There's the frequent on-site trainings. Do you feel there's a technology in India that probably we do not have it here? We're able to arrange this interaction, webinars. We're also able to arrange conferences where now you can be able to go and attend and feel like you're actually gaining something from this particular medical tourism organization. That is what we are. So we are not only supporting patients through the process, but we also think at the other players who are in this supply chain. That is the doctors. They do referrals to us, and then we also be able to support them in a different way in terms of upskilling on a different or new technology that's coming up, and many more. For now, I think that's the only time I have. We'll welcome Fiona to come back and guide us through the next step. Thank you, everyone, for listening. In case you have questions, I think we can be able to do it at the Q&A when it comes up. Prepare for it.
Well, thank you so much, Pancras, for that brief and concise introduction to YourFitPath, medical tourism company based in India and in Kenya. So for now, it's my honor to introduce our speakers to us. We will be having two speakers for this session. From Kenya, we have Dr. Alfred Mokomba Mogaka. He's a senior medical specialist in Kenyatta National Hospital, as well as a senior lecturer in the University of Nairobi. He's a consultant obstetrician and gynecologist with specialties in Gynae-Oncology as well as laparoscopic surgery. We also have Dr. Vikas Choudhary from Manipal hospitals in India. He's the HOD and consultant in the radiation oncology department. His field of expertise is breast cancer, head and neck cancer, prostate cancer, CNS tumors. And he focuses mainly on the radiation part of treatment of cancer. So without much ado, allow me to invite Dr. Alfred, who will be taking us through the first session of our webinar today. And then after that, we'll have Dr. Vikas to take on from there. So help me welcome Dr. Alfred. Dr. Alfred, you're welcome.
Thank you, Dr. Mokomba Alfred, as you have been told. Glad to join you. I'm a gynae-oncologist at the National Teaching and Referral Hospital in Kenya. So I'll be taking you through the introductory part of cancer of the cervix. I'll try and make it simple so that we can get as much info as possible. Fiona, if you can run the slides.
Pankras, the slides, please, for Dr. Mokomba.
Sir, kindly could you turn on the cameras if possible? Would be better.
Yeah, just give me a minute. I'm sharing the screen with you guys.
As you can see, cervical cancer is a fairly common cancer. And to start with, the cervix is that lower part of the uterus, the womb. And that's the part we are able to see on examination. And it is one of the commonest killers of women in terms of cancer globally. And like in our country, in Kenya, it's the commonest, it is the leading cancer that kills more women than any other. So you can imagine how serious that is. Probably the next slide. And it's mostly more prevalent in the less developed countries, sub-Saharan Africa. I think even India, it's a big problem. Parts of Western Europe and North America, they have reduced the incidence due to their rigorous screening. We can go to the next slide. So as you can see where the red indicators are, very, very common, South America, Sub-Saharan Africa, yes, and parts of Asia. Next slide, please. So the slides are not moving. Yeah, but as it continues, to continue, worldwide, it's estimated about 600,000 women get new cases of cancer of the cervix every year globally. And out of those, almost 300 actually die. You can imagine 300,000 women dying every year from this disease. That's huge. If you were to have, like plane accidents killing 300,000 people, it will be an outrage. So it is that common, and it is one of the most devastating conditions. So what you are seeing is the cervix, and what is the biggest risk factor for cancer of the cervix is now known to be infection with the human papilloma virus, HPV. In 99% of specimens from cervical cancer lesions or tumors, HPV has been found. And HPV is a viral infection. There are many, many variants of HPV, up to over 200. But the ones of concern is HPV 16 and HPV 18. Those two contribute over 90% of cases of cervical cancer. There are others. There are many other variants, but those are the most high-risk types. You have 33, 32, 52. But of importance to remember is the biggest risk factor is HPV, which is a sexually transmitted infection. It is estimated over 80% of people who are sexually active have at one point or another gotten infected with the HPV virus. And in majority of people with HPV infections, the virus clears spontaneously from the body through the immune system. Within 6 months, 50% of all those who have gotten infected with HPV, it clears. Within 1 year, the other, about 40% will have cleared. So it's in the 10%, 10-15% of where the infection persists. These are the ones who ultimately get cervical cancer. So that's why now these are, and the other important thing to remember is the interval between when one gets infected with HPV to the time they will develop cancer. There's a long latent period. It can take from 5 to 10 years, such that if one gets HPV today, they might now develop cancer in 2030 or 2035. And that is why the biggest weapon is methods to screen and prevent this disease. Next slide. Yeah, I've already alluded to that. The other high-risk types of HPV cause mostly warts. They can be genital warts, oropharyngeal warts, anal warts, etc. But these ones do not cause cancer. The ones I've mentioned, 16, 18, among others, are the ones implicated in the causation of cancer. Next slide. Okay, I think I've already mentioned that, but also important to remember that the HPV virus does not only cause cervical cancer, it causes other cancers as well, like cancer of the vaginal wall, cancer of the vulva, can cause penile cancer in males. It is implicated in anorectal cancers. It is also implicated in oral cancers, oropharyngeal cancers. Therefore, if like those who practice, anal sex, the risk of getting infected with HPV and anorectal cancer, those who do oral sex are at risk for throat cancers due to the effect of HPV. The other types listed there are the other high-risk types. Next. Yeah, I've already discussed about this. And the important thing here is to realize the HPV causes gradual abnormalities within the lining of the cervix, what we call dysplasia. That is why we do screening tests to detect these changes early and be able to treat them before the individual lady gets cervical cancer. Hence, the effectiveness of the screening methods. Okay, next slide. That explains how the HPV causes infection. There is any abrasion in the lining of the cervix or the vaginal wall or the rectal lining. So the virus settles, and viruses normally live in the cells. So once the virus lodges, it multiplies itself. If I may use lay terms, it replicates itself and multiplies to give many more viruses, which now spread the surrounding cells and start to cause the changes that I have talked about. Next slide. So I've already mentioned majority of those who get HPV infection, it clears by 1 year or 12 months. We expect almost 80 to 90% of cases will have cleared. Those where it persists is where the problem is. Next. Okay, we can move to the next one. I've explained that. Okay, that is still the science, how HPV causes the cancer. The HPV integrates into the normal cells, into the DNA, and then it replicates and transforms that cell from a normal cell now to a cell that keeps reproducing, even though it is abnormal, and that's how cancer arises. Next one. Next one, still that's part of the explanation. You can jump that. That's the diagram of what happens. Okay, now that is a picture of the cervix itself. That's how it appears on speculum exam. And that's one of the screening methods. We normally apply acetic acid, which is actually vinegar, like the one in the supermarket. And on the cervix, abnormal areas will turn white. Then we are able to take a biopsy from that particular area for analysis. That way we are able to catch these cases early, either early cancer or even before they transform into cancer. Next. Okay. Yeah, still an explanation of how that occurs is still the same thing. Next slide, please. Yeah, like we said, that is how bad this disease is. I have already alluded to those numbers. You can imagine actively around that high figure of people who are already affected by HPV, 630 million women and men. Next slide. I think I emphasized on HPV because that's the main risk factor. And remember, we said it's by and large sexually transmitted, although it can be transmitted on contaminated toilet seats, mostly. But the main mode of contamination is direct contact. So what are the other risk factors that will make somebody get cervical cancer? And all this relates to transmission of HIV. Those who have, the girls who have early sexual debut, because at that time the cervical lining is immature and cannot resist infection with HPV. Those who have many partners, because the more the partners, the higher the risk of getting infected with HPV. Those who have partners who have many partners, those who have immunosuppression, because the immunity is not able to clear. Cigarette smoking has been implicated. Those who get frequent sexually transmitted infections, the bacterial types, because that breaks the mucosa of the lining, and then they are liable to get these infections. Yeah, next. You could have the next slide. Yeah, thank you. I think I've explained that. Let's move to the next one. Yeah, previously the peaks of cervical cancer would see more women around age 35, especially those who are immunosuppressed. There's also another peak that is seen in women in their 60th decade. That's from 50, 60 years. There appears to be another peak at which we pick women with a lot of this. And this is explained by that fact of, from transmission, from infection with HPV. If somebody was infected at 25 years, the cancer shows up at that 5 years. Or if they got infected in their 40s, then the cancer will show up in their 50s. And we see this quite often. Next slide. Okay. I think we can have the next slide again. Yeah, I think this is a repetition. Let's go to the next slide. We have already had this. Also, the other important thing to remember is more common in areas where people have low socioeconomic status, because they are prone to probably engaging in higher risk sexual practices. So what happens? What do women feel when they have cancer of the cervix? Unfortunately, in the initial phase, the cancer is completely, there are no signs or symptoms. The women don't feel anything. They are completely normal. And this is why when we do screening, we are able to pick this. As the cancer progresses, then they start having an abnormal vaginal discharge, which would be watery and foul smelling. They would start having abnormal bleeding, starts with coital post-sexual bleeding, or if they, on exertion, they might cough or carry something on when they go to relieve themselves, then they'll see blood coming out. As the cancer spreads, then they start having pains. They might have pain in passing urine. They might see blood in their urine. And when the disease spreads to involve surrounding organs, these patients can get fistula, so they can have urine incontinence, they can have stool incontinence, and we see this quite a lot in advanced stages. If no treatment is offered, what happens? The cancer now encircles the ureter, which is the pipe that drains urine from the kidneys to the urinary bladder, and then it's obstructed. So there's backflow of urine back to the kidneys, creating pressure, and eventually they get kidney failure. And then they have complications associated with kidney failure. If it's not treated, actually, this is what kills these women. Next slide. Yeah, these cancers, the different presentations could be because of how it can present as a, a cauliflower-like growth on the cervix. Some it presents like an ulcer. There are patients where it is an ingrowing tumor. So when you do a speculum examination, you don't see, the tumor per se, but the cervix becomes large, what we call a barrel-shaped cervix. And most of the types is what we call squamous cell carcinoma, arising from the lining of the cervix, but it can also arise from the glands in the endocervix. That's in the lining of the cervical canal. Sometimes we get what we call melanomas, like the ones people got in the skin, you see a black spot on the cervix. Okay, so these are briefly some of the commoner types when these specimens undergo pathological evaluation. Next. Okay, then once these women are diagnosed to have cervical cancer, and that's mostly through taking a biopsy when you see the tumor that is growing. The next step is to do staging so that we are able to, from staging, then we are able to program the management pattern or how we'll manage these particular cancers, because different stages require slightly different ways of managing. Stage 1 of cervical cancer is when it's confined within the cervix without involving any other organ, and it's broken down into several bits, which I think we will not go through in this forum. Stage 2 is now when it has gone slightly beyond and it's involving the vaginal wall. Stage 3, it is involving, the bony aspects and the muscles of the pelvic wall. That is stage 3. Then stage 4, you have stage 4 where it is involving the urinary bladder and the rectum, and where it has spread to the other organs like the lungs. Now it becomes stage 4B. And basically staging helps you to program or to determine how you are going to manage a particular cancer. That's the most important relevance for staging. Yes. Next. Yeah, what are the other things we do apart in terms of the staging? Apart from the examination, the patient will be sent for imaging studies. Mostly it's MRI, magnetic resonance imaging of the pelvis. We might ask for a CT scan of the chest, a CT scan of the liver where it is relevant, where available, and we are happy now in the country, we have like 6 PET scan machines. Previously, patients actually would go to India for this. This one is able to show us whether there is spread of the disease. It's not diagnostic, but it is for staging of the cervical cancer. If it's gone to any part of the body, the PET scan is able to pick that. Of course, you can do other things like we said HPV can cause other problems, like in the rectum, you can do a colonoscopy. If it's the urinary bladder, you can do a cystoscopy, among others. Next. Yeah, how do we manage? I'll be very brief on this. For those with stage 1 of cervical cancer, what we offer is a radical hysterectomy with the pelvic lymph node dissection. So it's a surgical option where we remove the entire uterus, including the cervix. Like I said, the cervix is part of the uterus. We remove the surrounding tissue that are likely to be infected, and then we remove the lymph nodes because that's the mode of spread. The mode of spread for this cancer. So we clear all the lymph nodes around the vessels that drain the cervix. For those with stage 2A and above, there's those with stage 2A, who we will select for surgery, but most of the stage 2 and above, then they go for what we call chemoradiation. They are given some small dose of chemotherapy that makes the cells sensitive to the effects of radiotherapy. Then they are given radiotherapy, which is both external radiation of about 25 sessions, that's for 25 fractions or sessions, that's for 25 days. Then they are given what we call the radiation called brachytherapy, where they are given 2 or 3 brachytherapy sessions where there's a gadget that is inserted into the vaginal canal, into the cervix, then it is activated and the tumor is radiated. Among other things, of course, these patients have to get supportive care. Their blood level is low, you take care of that. If they're in pain, you take care of that. If they have infections, then one will need to take care of that. If they have kidney injury, then they'll need to be done dialysis, put diversion tubes, like what we call percutaneous nephrostomy tubes or ureteric stents, so that the patients are optimized for radiotherapy. For those who we get in advanced stages, then they undergo various modes of palliative care. Sadly, most of our patients reach us when the cancers are fairly advanced in stage 3 and above. And the other challenge, especially with Kenya, is the few centers with radiotherapy facilities, both in public and private. So sometimes our patients are subjected to waiting lists. And the other concern is, especially with the brachytherapy, we do not yet have the things like interstitial brachytherapy, which my colleague, I think, will take us through, which is fairly effective in treating these cases of advanced cancer of the cervix. So I would like to leave it there and hand it over to Fiona for the next speaker.
Wow. Thank you so much, Dr. Mokomba, for that concise presentation on the presentation of cervical cancer, as well as the risk factors. Maybe, Doc, before we go to the next speaker, I'd like to, there's a question that was raised as we were collecting the information. Someone asked, what is the benefit or rationale of giving 3 to 4 doses of cervical cancer vaccine to adults already sexually active and presenting with the cervical, the changes, the intracervical changes that we see in like the CIN? What's the benefit of doing? Maybe you could speak on the vaccination for the younger child, for the younger age, as well as vaccination for the sexually active woman.
Yeah, the HPV vaccines, and there are several variants, are given to prevent either infection with HPV or help the body's immune system to eliminate those already were infected with HPV. So the vaccines are started from age 10 onwards, and for children, the vaccines, the best time to give is before one gets infected. And that's the rationale for giving children before they are sexually active and they are infected with HPV. So it prevents, and actually it should be given to both boys and girls. For those who have missed the vaccine, there's what we call catch-up vaccine. So long as somebody does not have cervical cancer, they actually benefit from the vaccine, because what it does is it has been shown to be beneficial. What it does is to boost the immune system so that it is able to detect the HPV and eliminate it. And so long as even women who already are at risk of having had HPV, remember we said majority will eliminate it through the immune system. So when one has HPV and is given the vaccine, that will trigger the immune system to eliminate the already existing HPV infection. That's why we vaccinate even adult women, and it's been shown to be useful up to age 45 years and below. I hope that explains it.
Yes, it really does. Thank you so much. I know there'll be more questions from the audience once we finish the other presentation. So towards the end, Doc, I'll invite both you and Dr. Vikas to take us to answer some questions from the audience. Lovely audience, if you have any questions, you can be preparing them. Once we finish the presentation with Dr. Vikas, we'll be opening the floor to anyone who'd like to ask a question, and the chat will be activated. So for now, I'm going to invite Dr. Vikas Choudhary, the head of department as well as senior consultant in radiation oncology in Manipal Hospital, New Delhi. Kindly help me welcome. I hope, Pankras, you're ready with the presentation. Yes, I can see you're already presenting. Welcome very much, Dr. Vikas.
Yeah, hi, good evening, everyone. From this side, I don't know what's the time there. And there's a great presentation by Dr. Alfred. And thank you so much for inviting me for this session. So today we'll discuss about the management of CS cervix. I think my voice is good. Is audible?
It is audible.
Yeah.
Yes, you're audible, Doc. Thank you.
Okay. So please move on with this slide. So we'll go for the overview and take home message from this session. So for the CS cervix, we divide it mainly in two stages: early and the locally advanced. Yeah, second slide. Yeah. So early till stage 1B2. That means stage 1B2 means less than 4 centimeter, and disease confined to the cervix only, not going anywhere else. So for early, even surgery is equally good. We can go for the either for the surgery or radiation alone can be done. For locally advanced, from stage 1B2 till stage 4, chemo radiation is the standard gold practice all over the world, and it is supported by lots of evidence which we practice. So for stage 1B2 till stage 4, radiation. So radiation will have two components. One is external beam and the other one is brachytherapy. And chemotherapy is weekly, which Dr. Alfred also mentioned. It's low dose to sensitize the radiation more and to give more effect of the radiation. So it acts as a radiosensitizer. That is a cisplatin, which we give weekly for 5 weeks. Please, next slide. So stage 1B1 till there, radical hysterectomy is the treatment of choice, and it's equally good as per the radiation, and that's very well mentioned in Lancet study by Landon and et al. So as per this and as per the GOG 92 updates, we go for this one. Either radical hysterectomy is equally good or radiation alone is also equally good. Next slide. So when to give after surgery, if surgery is done, and when to give the radiation, what all are the indication for the radiation post-op? So most important high risk features which indicates towards the radiation is LVI, lymphovascular invasion, bulky tumor with stromal invasion, lymph node positive, margins positive, parametria positive. So conclusion, after surgery, radiation is required in about 50% of patients. And if surgery is done and followed by CT-RT is done, the results will be almost same, but toxicity increased to many folds. So standard of treatment is CT-RT. CT means it's a short form of chemo. RT means short form of radiotherapy. That is RT. Next slide, please. So now we discuss about the conventional versus conformal technique in EBRT. EBRT is the first component of radiation, that is external beam radiotherapy. Conventional means the old techniques by which we used to give the radiation, that is two decades back. Now the advancement is there in the technique, and we are more conformal, we are more precise, we go with the more precision and accuracy. So I'm discussing about this thing. Earlier in the conventional ones, we just do a bony landmarking, and we used to treat in a box field like anterior, posterior, and lateral side. But now on the conformal technique, we'll just go for a scan first, and then accordingly we'll go till we'll target sets till common iliac nodes and laterally external iliac nodes, and the same about the site in the pelvis were all to include. So there is very less chance of any geographical miss or failure from the margins, which were earlier very common because all the females don't have the same type of the pelvic girdle, or the same at the same level they don't have the same bifurcation from the common iliac or from the common aorta. So many a times at that in old days we used to miss the many of the lymph nodes, and then recurrence used to come. But now with this newer technology with imaging and everything, we able to delineate properly. Like the surgeon used to operate in OT, we easily we dose paint in our system, in our planning stations, and then we decide ki, okay, now everything is covered, then only we'll go for that. So that all comes under contouring part. Next slide, please. So why it was needed for the improvement in the technologies? Why we come from a box field technology to this imaging technology and everything, just to reduce the toxicity both acute and late, and to treat the para-aortic nodes, which was very it was not easy to treat earlier when the disease was going from pelvis to the para-aortic nodes. That time with the conventional technology it was very difficult. When you used to treat, there was very high toxicity to the bowel. Bowel used to go GI toxicity was very high. So to reduce that toxicities and everything, the technology was improved, and to boost the pelvic nodes where the nodes were there, we used to give like a little extra high doses, like for say if we give to the pelvis 45 gray in 25 sittings, then if any gross node is there, we try to give around 54 gray in the same 25 sittings. So that is a very good tumoricidal dose which able to completely vanish off the pelvic nodes. So and by this we decrease the morbidity and chances of recurrence in the later part of the life. Next slide, please. Hope I'm not that fast. Everyone is getting a few points because these are more of technique and skill related slides, and letting the I'm just putting a points for the modern technology. What's they how they are apart from the conventional ones. Hope I'm going slow only, and everyone is getting. So advancement in use of radiotherapy in the treatment of cancer cervix, it is about the diagnosis and imaging, which already Dr. Alfred talked already about the CT scan, MRI, PET, and the same thing we use in our planning system, like contouring for contouring techniques and to the target volumes. And there is an advancement in the external beam radiotherapy, that is we moved from box field to 3D conformal to IMRT, and now SBRT and IGRT and VMET. There are lots of techniques. There is a big difference between the 3D, IMRT, IGRT, VMET, and SBRT. These all are different types of techniques in EBRT. Same thing we are doing in the brachytherapy. We are doing image guided brachytherapy, interstitial brachytherapy with the help of the modern instruments and other things. So, and with the modern systems which calculate the doses. So there is a outcome is also better of radiation by these improvement in the technology. Next slide. So now I just want to discuss about the role of PET-CT. What is the role of PET-CT? The first and foremost primary role is about it helps in the staging also, lymph nodal staging very well. We can pick up the any small lymph node also we can pick up. Either it is if lymph nodes are there, either it is early or advanced stage, pre-treatment prognostic value it gives, treatment plan optimization, like whether we need a single modality post therapy, and it helps in the surveillance also later on the after post therapy surveillance, like is there any local or regional or is there any distant meds. So we if any patient comes to us and PET-CT is not done, then we try to do PET-CT based RT planning scan. So in PET-CT based RT planning scan, how it is differ from a normal PET-CT scan, we use a flat couch and we try to put the same mold immobilizing cast which we use during our day-to-day radiation, that is for 25 sittings, which Dr. Alfred already explained. So with that couch and with that immobilizing device and everything and our flat couch, we'll take a PET-CT scan. First, we do of whole body to see if is there any distant mets is there or not, and then we target the same pelvis part only where we need to give the treatment. So by this, that PET-CT help us to delineate that particular target properly, and we go for the contouring, and then we'll go for the planning, and then as per the after evaluating the plan, we'll go for the radiation. Next slide, please. So MRI. So MRI is the gold standard for evaluation of cervical cancer. How it indicates that about the diagnosis and local staging, any burden of the nodal disease, also pelvic and para-aortic. It also helps in the RT planning, like PET. PET helps like for the gross tumor volume, we need an MRI. So MRI help us about the where's the exact epicenter of the disease and where all it is there, right? At the center of the cervix, or it is involving the para, or it is involving till it's going till pelvic wall or whatever. So with the help of MRI, we delineate that thing on our CT planning scan, because the main planning scan is CT only. On that, we'll superimpose our MRI film, MRI CD and films, and then we'll delineate that part, and then accordingly we'll give the radiation for the external. And same thing we'll use it for image guided brachytherapy, that is IGBT, and it helps later on for the response of the treatment. And if there is any recurrent disease or any fibrosis, so that can be easily detected by an MRI pelvis. Next slide, please. So during the treatment, we need to judge about the internal target motion, because if some there is some motion is there, and if because our targets are steady, and we need to know how much motion will be there in the bladder, how much motion will be there in the uterus, and how much motion will be there other our the about the bowel which is coming down in our target, and about the nodes. So accordingly, like there are lots of studies been done, and accordingly by patient specific motions, we give that some margins around that one. So that's up to even 40 that is 4 centimeter, and it is for the nodes around 5 to 7 and for different for the uterus also we have to see, because to completely know exact how much motion of the uterus or the bladder or the rectum and feeling, that we do by doing a daily imaging, and then we'll see if whatever the plan we implement, and in the first 3 days the plan is not coming the same, then we again redo the planning, and we again resubmit our case with the better margins, so that we can include each and every target with at the same time looking for the motion, whatever the motion is there in the target, and the OR. OR means organ at risk. We have to at the same time we have to save whatever the organs, normal organs are there nearby the target, that is the bladder and rectum, and at the same time we need to target cervix, and nearby the things wherever we need to give the dose. Next slide. Next, yeah. So now, what is the IGRT in CS service? What is the role of IGRT? IGRT means image guided radiotherapy. So that may be either by IMRT or VMED, but IGRT is very important. So IGRT means daily imaging, which I already explained you. By doing the daily imaging, we try to keep precision on the day one of the scan, that is a planning scan, and from day one of the treatment till day 25th sitting of the session, we try to implement the same thing, try to replicate the same thing, and then only we'll treat. If there is some deviation, then we don't go with that. We try to again we do the imaging, and then we try to set the target, and then we'll treat it. And it is done either by in room by CBCT, that is cone beam CT, or by EPID. These two are there in our modern Linux. These two imaging modalities are available, which help to give a imaging guidance. And the CBCT is the best, and that is available in our center. EPID is little bit of more superficial, and accordingly we'll do it. And I just want to explain you about 2 3 words about the bladder protocol. So bladder protocol means every time patient when going for the radiation, we first ask to empty the bladder, and then instruct for 300 to 350 ml of water. And once the patient feel pressure, that time we'll take the patient on couch for the treatment. So what it helps? It helps to replicate the same bladder capacity which on the day one we take for the scan. So same thing we want every day. Either just a 10 to 20 ml is okay, but if there is a difference of like day one 300 cc volume, and on day 5 it is 200 cc volume, then we're not doing a proper radiation. So we need to do exactly the same. So by this bladder protocol we able to give. So what it helps? First, it gives lesser dose to the bladder when it is inflated, and the second thing, when bladder is completely inflated, it push intestinal loops above, so the scattered dose to the intestine also decrease. So bladder protocol plays a very big role in CA cervix in modern radiation era. So please, the second set of slides, please share that one. Yeah, Mr. Pancras. Yeah, the other one, the second slide. Second, yeah, this one. So this is the second component of radiation, which is brachytherapy, internal radiation. So this is Jack Astro. I directly from the Jack Astro I took these slides. So these slides give a very complicated things about the how we decide about the targets when we are giving the internal interstitial brachytherapy or intracavitary brachytherapy. So initially, historically, it was very difficult to communicate ki how to give, because earlier we used to plan on X-ray base, 2D base. So that is two-dimensional base. So that time our target was only to give a reference volume of 60 grade to be around point A. Point A, just it is a arbitrary point A in our language, which we try to give around 60 grade to that point. So these are the recommendation which all over the world we try to follow as per the evidence. So there is some uniformity all over the world. As a radiation oncologist, we try to give the same target volumes and definitions so that everyone can get understand. GTV means gross tumor volume, HRCTV means high risk clinical target volume, and IRCTV means intermediate risk clinical target volume. Next slide, please. Next slide. Next one. Next one. Yeah. So here about the definition which I was explaining, above one. Number three. Number three. PPT number 3. Yeah. So here I already elaborate about what is HRCTV, IRCTV, and GTV. But I just now going to explain this pictorial that GTV is the main tumor, the disease where the over the cervix, and HRCTV is the part where the disease uh, is there, is chances of high chances ki the disease must be there but not visible. And IRCTV is the volume where the disease chances of spread is there. So there is a difference between IRCTV and HRCTV. So GTV, which we can see by naked eye or on imaging, HRCTV, that's the place where disease must be there, but we're not able to identify. And IRCTV, where the disease can go till there. So accordingly, we define the volumes, and accordingly we'll give the doses to that. Highest dose to the GTV, that is 200%, then HRCTV around 120%, and IRCTV around 90%. Like this we make the target volumes. Next slide. Next slide. Yeah. So this during the treatment, how the things change. This is from this we can see if there is a high single intensity of tumor mass which is reduced post EBRT and chemotherapy. So still there is a residual. Earlier it was, if you can see, it is a big mass. If you can identify, there was a big mass in the center, and later on it was just a residual, a small, very small part. So that gray zone in the parametria, that is just a little bit of residual, that is after EBRT and chemotherapy. And the same thing, if you see in the corpus, initially it was going up and then it is reduced signal intensity, which we can identify. So these things help to target properly in the brachytherapy. Okay, this is the residual, here we have to hit maximum. So for the accuracy, these scans we go take on day-to-day activity. Next slide. So here, this is about the target volumes, which I explained how to define that. That is a cervix macroscopic tumor load, that is high risk, and then potential microscopic tumor spread, which I already explained you, that is low risk, and significant microscopic disease, that is intermediate risk. So these all about the how to define that growth. It is about that one where we can see the tumor and where the chances of significant microscopic spread and where is the potential microscopic spread. Accordingly, we'll define the volumes. So it is a very tedious job how to define, and there is a set guidelines for everything. Where all the, if tumor is this side, if it is going to the left para, where all it can go, and how much it can move further. These is decide that we can see from our guidelines. We follow the guidelines for that. Next slide. So the again about this is about that same thing, pictorial explaining about the extensive disease in stage 2B to 4. Here about the tumor in between, and it is just confined to the confined nearby to the cervix. Next slide, please. Next one. So it is again a pictorial showing. Yeah. So here in this slide, according to like after EBRT, complete remission, good partial remission, poor partial remission, and no remission. Accordingly, we'll give the we set the targets, and we make a target volume, and then we go for the brachytherapy so that we can give the maximum dose where we need to give, and at the same time save the uh, normal normal organ or normal structure nearby. Next slide. Next one. So these are some clinical examples where the limited disease means tumor size less than 4 centimeter, large tumor sufficient response, large tumor insufficient response. So few pictures are there. So no need, we can pass on these, please. Yeah, pass on, please. These are the examples which Jack has to also tell, and it's about the tumor response after EBRT. So initial findings and about that. So it is applicable. Jack Astro recommendation are also applicable for gynae brachytherapy, in general for the vagina, endometrium, vulva, and recurrent tumors. So we go through the guidelines. So this slide particularly just to tell ki, it is not a independent practice or a self practice. It is a practice by all the radiation oncologists, and it is as per the guideline we go, and that can be easily shared between the any, not even intra department. It can be interdepartmental. We can send the pictures whatever we done, and we can send the details what we treat here in India and to the physician in the Kenya or to any other part of the world. Yeah. So these all about the now the MR by MR imaging. We go for this brachytherapy. Earlier we used to do by only by the X-ray base and ultrasound base. Next, please. I think it's
That's the
over.
last slide, eh?
Yeah, yeah,
It's
yeah.
over.
So the third PPT, I just want to put in one more PPT. I just given one PDF. Yeah, this one. So this paper, I just want to tell ki what I'm again and again saying about the evidence-based practice, how we go for a contouring. Contouring means to delineate the targets. So this is about the para-aortic lymph nodes. When the practice is started changing and the advancement comes in the technology. So this was the one landmark paper which was published in 2018, and we started following this one as per the atlas, how to delineate the para-aortic lymph nodes in cervical cancer. So everyone uniformly practice like this. How much margin we have to give around the aorta, how much margin we have to give around the IVC, and how much margin we have to give around the node. So accordingly we do everywhere. So that helps to reduce the toxicity to the bowel, and at the same time to not to miss any of the target. So by these are the way by which we establish our contouring guidelines, and we practice the same whenever any landmark papers are there. We keep with us and we follow that only. So that's from a very reputed green journal, and that was published later on in red journal, which are the most reputed journals of radiation oncology. Yeah, that's all literature. Leave it. The main purpose was to tell ki how we go and how we do the practice. It's about that one. So before finishing now, I just want to let you know what type of LINAC we are using. So ours is True Beam Linear Accelerator here in Manipal Hospital, Dwarka. So with this STX, that is around 2.5 MLCs. So we treat not only here about the cervix, we treat from head to toe everything. We do SRS, stereotactic radiosurgeries. We do FSRS. We do SBRT. We do here all VMAT, that is volumetric arch therapy, rapid arc for all the sites. We are doing that rapid arc only with image guidance. Those patients come from abroad for with the hope of better treatment. We give them best of the treatment irrespective whatever they are paying to us. But our main purpose was to keep though our quality high enough so that once they go back to their country, they go back happily. That is our target, and we are doing with the latest hypofractionations wherever it is required, like less number of fractions and more number of more doses, so that the logistic also problem should be reduced, because it's very difficult for those who are come from abroad or from Kenya or from any part of the world and to stay here for long time. Like for earlier for the prostate, it's about 7 and more than 7 weeks. Now we are completing in 4 weeks only. So these all we are doing here at Manipal Hospital, Dwarka. Now question and answer. If anyone want to ask, I'll just ready to reply.
Fiona, do you have access
Wow,
to other?
thank you so much, Dr.
Yeah.
Dr. Vikas, for that. It was
Thank
quite
you.
a
Thank you.
concise presentation. Thank you very much. I'll now invite Pankaj to take us through the Q&A session. So to the audience, I think Sagni, you can enable chat as well. If you would like to ask a question, kindly raise your hand and then you'll be unmuted and you can ask the question. You can choose to direct the question to either of the doctors. Yes, so Pankaj, over to you. Thank you.
Yeah, thank you very much. So I think we can, anybody who has a question, feel free to quickly just raise your hand and then you'll be able to be the first to go. So checking out on the chat. And I'm able to see, okay, Wilson, do you have a question? Please unmute and then ask your question. Make it as brief as possible. Wilson, you raised your hand. Please ask your question.
Just to confirm, may I get to know the difference between the pelvic exam and a pap test?
Hi, Doc. Are you able to hear that? Any of the doctors I think can be able to handle this, feel free.
So that's the difference between a pelvic exam and a pap smear, if I got him right. A pelvic
Absolutely.
exam is basically a vaginal exam where we do a digital exam to feel the cervix and the vaginal walls. We can also do a speculum examination where a speculum is a gadget we put, then we're able to visualize with the naked eye the cervix. A pap smear is an examination where we pass a brush that picks the cells from the cervix and then we take them to the laboratory for analysis.
Brilliant. Next question. Maggie, I've seen you've raised your hand. Maggie Kibathi. Okay, there is a question in the chat and they're asking, while Maggie is thinking, can one still conceive when she has cancer? Vikash, I'll let you handle this, please. Dr. Vikash?
Yeah. Definitely, if someone conceived, then we have protocols for that. In pregnancy, how to treat CS cervix. We try to, if pregnancy is in the later stage and we come to know about that, if it is detected, then we try to first let's delivery happen and then we proceed for the radiation. It is very early in the stage, like in the first term, so we ask them to better to terminate the pregnancy and then to move on for the treatment, because the radiation itself cause so much abnormalities later on, so it's very difficult to give a very healthy baby. So if there is a necessity, like a couple is there and they don't have child and lately conceived, so we try to see, we discuss with ops doctor ki whether how long it will take for the pregnancy and how it can be forwarded. If surrogacy can be possible for them, then we try to do it. But during when the if in the womb something is there, so as per the protocols, radiation should not be given.
Thank you, Dr. Vikash. I hope that answers your question, Rachel. I see I see Lorraine Akoth. Would you unmute and ask your question, please, Lorraine?
Oh.
Lorraine Akoth, please. Lorraine, you raised your hand. Do you have a question?
A question.
Yes, please.
Can colon cancer be detected at an early stage at 1 year? Can it
Sorry?
be detected?
Sorry, come again.
You're not very audible. Just say that again close to your mic, please.
Just asking.
Yeah.
Hello.
We can hear
detect
you.
Cancer at can you hear me?
Yeah, just say it close to your mic, please.
Can we detect cancer at an early stage at around 1 year?
Dr. Alfred, do you want to take this one, please?
Yeah, the cancer can be picked at stage 1. That's why we do things like pap smears and other tests before one gets cancer, so that if there are any changes that will lead to cancer, we are able to take care of it. Or even those who have early cancer, then we are able to catch it at that point. Yes. So through regular screening tests, we can get it early, even before it gives any signs or symptoms.
So I just want to
Really?
add on this.
Yeah.
I just want to have an add. So for the cervical cancer, screening is very, very important. And for the screening, pap smear is the cheapest and easiest way to find it out. And every sexually active woman, they should go for the pap smear yearly once. I think I'm right, Dr. Alfred?
Yes, you're right. Yes.
Yeah. So it's very easy and it's a very on the just hardly 5 minutes for the pap smear, and they just easily they can take out time from their busy schedule and go to any gynecologist, and they do yearly once for the pap smear while they are sexually active. That is very important, which we here in India also try to practice that one, though the population is the main concern here, but we try to do wherever it is possible.
Thank you very much. I hope that satisfies your answer. One more question here. I don't know. Sophia Waisiko is asking, hi, Doc. Can a sexually active female have human papilloma vaccine, or is it only available for teens?
Yeah, I think I talked about that. There is what is called the catch-up vaccine for the women who are older than 16 years. There's the catch-up vaccine. Yeah. So they can get, yes.
So the audience,
so in as per the guide, just a minute, Mr. Pankaj. So for as per the guidelines, that vaccine should be taken before the any female is going to become sexually active. But if already they are active and it is missed earlier, then they should take it, because if they take it, then still there is a chances they can have a good chance of prevention. So as per the guideline, it is before they become sexually active, they should go for the vaccine. But if it is missed, they should take it now. I think I'm right, Dr. Alfred?
Yeah. Yes, you are.
Thank you both. One more question. Hello there. What are the signs and symptoms of cervical cancer? Like, is this something that can be able to be seen away from going for pap smear and those kind of tests? Alfred, Dr. Alfred, you want to take this?
Yes, I think we also talked about that. In the initial stages, there are no signs or symptoms, and that is why what Dr. Vikas has said, go for the regular pap smear checks. That's the only way we will be able to pick it late. If you wait for the symptoms, which are things like an abnormal discharge, abnormal bleeding, then it will be late. It will be late. So in the initial stages, there are no signs or symptoms, but it can be caught if one goes for regular screening. Do not wait for these signs. Go for regular screening. so that we're able to catch it early where treatment is effective.
So thank you very much, Dr. Alfred. I hope that answers your question. So Sapna Bibi is asking, she has a question. So what are the stages of cervical cancer? Dr. Vikas, do you want to take this?
Definitely, yeah. Already explained by in one of the slide by Dr. Alfred, but still I want to again clarify for the stage one, especially it is confined to the cervix. So stage one is divided into stage 1A1 and stage 1A2. A1 is like stromal invasion less than 3 mm and depth less than 3 mm depth, and the width is less than 7 mm. A2 is less than 5 mm depth and width is less than 7 mm. Now stage 1B, that is divided into two parts. 1B1, that is clinical lesion less than 4 centimeter, and B2 is clinical lesion more than 4 centimeter. Then again comes about the stage 2. Again it is divided in A and B, two parts. So this is about extension. The now tumor is moved out of the cervix but not going to the side walls. So A stage 2A, that involves only upper two-third of the vagina, and 2B is about the parametrial involvement. For stage 3, it is extension to the pelvic wall and lower third of the vagina and hydronephrosis. So stage 3 comes again in 3 A and B. A means only lower third of the vagina, but B means side walls involvement and hydronephrosis. Hydronephrosis means it is back pushing the for the pressure to the kidney, so that that ureter is again dilated and giving the pressure to the kidney back. And the stage 4, that is uh, tumor move out of the true pelvis involving the bladder or the rectum. When to rule out for the stage 4, as Dr. Alfred already explained, if need to rule out it from the bladder, we need to do cystoscopy. To rule out from the rectum, we need to do sigmoidoscopy, but not for all the tumors. Only when we have the doubt, that time only we have need to go for the cystoscopy or sigmoidoscopy. And if it is a stage 4 2, that is true pelvis and metastasis to other parts. So these are very simple staging. So main thing is to know if it is less than 4 centimeter, then it's really a great thing, because as the tumors, as the staging increase, the chances of complete cure decrease. Like for stage 1 and stage 2, it is more than 80% chance of cure rate, and when it is stage 3, it is around 60, and for stage 4, it is around 40%. It still holds good. But what I explained earlier, for stage 1B, from B2 till stage 4, radiation with concurrent chemo is the standard of practice. But if it is stage 1B1, there you can go either with the surgery also or with the radiation also. Equally good. Both have the equal results.
Handled incredible. Thank you for your response, Dr. Vikas. Now, I think I'll pass this on to Dr. Alfred. So Jen Mumbi is asking, hey doc, can one successfully conceive after the cancer is gone? And they're also asking, does the human papilloma virus affect males as well?
Yeah, HPV affects males, not as much as the females. Like I've said, it can cause penile cancer and anorectal cancer, which can affect either gender. Can one get conceive after treatment for CS cervix? In most cases, natural conception is difficult, because if it's the early stages, then we remove the uterus. We might spare the ovaries. For the advanced stages after radiotherapy, then the ovaries are also absorb a good amount of radiation and ovulation cannot occur. So the only chance one has is if we catch it early and then we do surgery and we spare the ovaries, then the ova can be harvested and then one uses a surrogate mother to conceive. Yes.
Thank you.
One more thing.
Yeah.
We those Those who want to conceive later on post treatment, we ask them before the start of the treatment, go for the egg for the ovum banking. So by that, once that their ovum is frozen, then it can be do by the surrogacy instead of going for any surgery or anything. That's the best part nowadays. We are doing it in India very well. So if it is feasible in your country, then I think that's a very good initiative where that can be done for the things, because before start of the treatment, when we ask them and if they want to freeze their eggs, then it's really great. It's really great without any issue. They go for a good like a healthy child.
Just allow me to check on time before I proceed. Sagnik, how much time do we have so that I know how many questions I can be able to accommodate for the doctors? I don't want to keep them here more than
So
10 minutes.
only 5 to 6 minutes up till 10:08 we can just take the questions and then we can wrap up this meet. So.
No problem at all. So Dr. Alfred, or anyone can take this. So does reduction, so Esther Kingara is asking, does reduction of tumor makers for stage 4 patient mean cancer is gone?
For cancer of the cervix, there are no reliable tumor markers. What we do after the treatment, which will be radiotherapy now, is to do clinical examination, then we can do imaging. Especially the PET scan is great at showing us whether there is any cancer left or if it's cleared. So the most reliable actually is a PET scan imaging, but not tumor markers for cancer of the cervix.
Okay.
So we could take probably 2 or 3 questions via mic as well. They are raising their hands, so we could take around 2 or 3 for that.
Okay. So I think there's some questions here that probably we've already taken care of. Any tips to make a woman less scared of going to a doctor for checkup? So I think this is, I don't know, Dr. Vikas, do you want to help with this?
Yeah, for going for the checkup is like if there is some change in the body, or so there is some change from the routine things, if there is abnormal discharge is there from the vagina, or if there's something bleeding is there while post-coital bleeding is there, or something is there, then they have to approach doctor. Otherwise it's okay, they can live a routine life. But if any symptom, anything, then definitely they should not ignore it. They should immediately rush to any doctor so that a further evolution can be done, because early is always better to cure.
So one last question I do have for Pancras as well. We have from one last question from Dennis as well. It's what are the steps needed to take to get to India for the treatment, and can I go to any hospital? It's for Pancras.
Yeah, brilliant question. So what are the steps for you to be able to get to India? First is you just contact us, as I've taken you through the PPT. So the most important thing is for you to be able to have like documentations of diagnosis locally here. The treating doctor gives you a report. So using that report, we're able to identify, using our experts in India, we're able to identify the right hospital to be able to treat you, and the specialist as well. That is your documentation from the doctor treating locally informs us on which hospital we're able to reach out. It's Manipal, and then probably we decide it's Dr. Vikas, who's an expert in that particular area. Once we have a look at that, then we're able to get a quotation using your documentation, and then moving forward after that, we guide you through the process of getting the right documentations to get to India, including passport and immigration documentations as the visa, and so on. So there's obviously the yellow fever as well. These are the details. And then from there, we help you, like, for example, if getting the air ticket, and then you can be able to start your journey. You get to India, our team supports you in where to stay, and then finally you get to the hospital where now Dr. Vikas and the rest are going to be able to take care of you. It's a very simple process, very seamless. We don't let you do it. We actually support you all the way. It's very, very easy. I hope that answers your questions, Dennis. Alternatively, you can actually visit our office, which is located at Riara Road, where now patients normally sometimes send the caregivers to be able to engage with us one-on-one. You can take our number or find us online on our website, YourFitPath.com, where you can engage us. You can actually get a quotation. You can ask questions, and we can actually call you back to give you more details regarding what exactly we do and how we can be able to help. Thank you. Diana, you here? You're back?
Yes, I am back. Thank you very much. Apologies for time is not on our side, so we may not be able to handle some of the questions. I think maybe as we bring it to a close, thank you so much, Dr. Vikas. Thank you so much, Dr. Alfred. I think it has been quite an informative session. Thank you so much, all our participants, for joining in and for allowing us your time to be able to learn about the cervical cancer. This is an ever learning. Cervical cancer is something we have to keep learning over and over. And I just noticed someone with keen interest in asking about what is the best way to help women be less scared of coming for doctor's checkup. I think, as I close, I'd like to say early detection means early cure. And cervical cancer is one of the cancers we say is almost curable, because if you can make sure you don't get the HPV virus in the first place, then, or even if you get it, if you can treat the virus, then that means you won't progress to getting the cancer itself. So if you can do vaccination, prevention, and after the age of 25, if you can always try, go to your doctor, have a pap smear done, have a BRVLI done, or come for regular screening, then that means any slight change will be detected as early as possible and will be dealt with as early as possible. So thank you very much, everyone. We shall be sharing the PowerPoint to the email that you registered to for the attendees. So, and if you have any questions, you can still direct them to us, and we can direct them to the various doctors to get responses even afterwards. So thank you very much. Thank you, Manipal Hospital. Thank you, Dr. Alfred from Kenyatta University, and looking forward to the next session. Have a lovely and wonderful evening.
Thank you. Thank you, everyone. Have a good night.
Thank you. Thank you. Thank you.
Okay. All right.